Okay, hello, good evening, and welcome to this week's The Double 15 Minutes with me, Rupa, and my amazingly wonderful, beautiful guest, Reena Patel. So, Reena, thank you so much for joining me this evening. How are you?
Very well. Thank you for having me. I'm super excited to be on this platform, but at the same time, nervous as well because usually it's the other way around and I'm asking questions. So it feels strange, but nice to be the opposite side.
I know it's a real sort of like pushing you way out of your comfort zone. But for those of you joining us live this evening, we are streaming live across Facebook, YouTube, and LinkedIn. So there is a comments box on whichever platform you're watching. Please leave your name and let us know where you're watching from. Today's guest, like I said, is Reena Patel. Now, Reena is a practice nurse within primary care. She's a diabetes nurse specialist, and she is also a lead nurse advisor with the CCG. So, and that is in Leicester City. Outside of that, Reena is also a lead nurse for an aesthetic clinic, Dr. Skin, as well as I suppose, a contributor, an author, a writer within a number of medical journals and medical magazines. So, Reena, I don't think I've done you enough justice because the other thing that you may or may not know about Reena, for those who are watching, is that Reena was also the recipient of the Nurse of the Year award in 2017, which is a national within GP practice, and that is a national award. So, literally, out of all of the nurses in the UK, you won that award. So let's talk about that award first. How did that come about and how did you feel?
Mm. So first of all, I wasn't even expected to be shortlisted. In fact, I didn't know that the practice that I was working for at the time, which was Croft Medical Centre,
Mm.
actually put my name forward. So what they effectively did was they put together everything I did in my entire career up until then, and
Wow.
then forward for this award. So at first I was like, okay, well, this is a privilege just to be shortlisted. Um, so I was in shock. And as you go and you think, oh, okay, fine, this is a nice event, everybody's glamorous, dressed up, and I was actually just going to go and just get a reasonable dress from Primark or something like that. Be quite
Mm.
happy with that. And then one of my friends said, "Well, what if you actually get the award?" I'm like, "Don't be so silly." She goes, "No, no, no. You should buy any dress." I was like, "Yeah, all right, fine."
Mm.
And I was shocked because I wasn't expected to get it. And every time I talk about it, I get quite emotional about it
Yeah.
because the way I see it as what I do, it's my job. And I think if you work for the NHS, it's a
Mm.
privilege to be in that position where you're making a difference not just to your patients, but also to the general public. So it was a totally unexpected award, and I must admit, I was like, yeah, I have no words to express my gratitude.
But I mean, that's amazing. And and obviously very well deserved as well, because, it's a to be nominated, like you said, is a privilege, but to win it out of all of the amazing nurses that are that are nominated, it is such a huge achievement. And thank you for thank you for being so humble about it, but you are extremely humble about winning that. But really, you've been so active within Leicestershire and Leicester City when when it comes to diabetes education, making sure that your patients are actually doing the right thing. So we're going to move on to that conversation now in terms of like the diabetes side of things. So what exactly, firstly, is a diabetes nurse specialist?
Okay, so in primary care, majority of the type 2 diabetic patients are looked after by the GPs and the
Mm.
nurses. Okay? So there are some practices which we call enhanced practices.
Mm.
So those practices generally have a trained practice or practice nurse that's trained in diabetes, and you have a GP that would lead. the diabetes care and diabetes. So those patients that are quite complex, that might need insulin, weekly injectable therapies, all that, which let's say 20 years ago was managed by secondary care, is now managed by trained GPs and trained practice nurses in primary care. So secondary care, you've got patients that have type 1 diabetes, patients that want to sort of, for example, if you're pregnant, planning a pregnancy, or if you're a renal patient, patients on dialysis, really complex patients that need the expertise of a consultant would be under secondary care. So this allows patients to be seen nearer to, closer to their home, so they don't have to go to hospitals. And in fact, in Leicester, we're so lucky that we have top consultants like Dr. Kamlesh Kunti, we've got GPs like Trivedi, we've got Ian Lawrence, so we've got amazing support. So even if I need that extra piece of advice or I need to do a referral, we all work quite well, very closely, which would one prevent an admission, prevent acute admission for a patient, whether that's a hyper for a low sugar. So I guess that's the role. Nursing and primary care has changed so much. So a lot of things that the practice nurses used to do years ago, 20, 15 years ago, is being done by trained healthcare assistants now. So, and it's just the way the workforce is now. So therefore, a lot of work which would be done in secondary care, we've had to upskill community pharmacists, upskill in-house pharmacists to manage diabetes because the rate of diabetes is just going up, and that's the only way we would manage it in-house, basically.
So I'm going to take this right back to basics in terms of questioning, because it's like we hear the term diabetes, so much, and we know that, okay, it's I suppose an illness that, depending on which type you've got, can be managed. But what is the actual difference between type 1 diabetes and type 2 diabetes?
Okay, so type 1, well, let's go back to the function of insulin. So we have an organ called the pancreas, which makes insulin. So this insulin is a hormone which allows the glucose to enter your cells so you can use it for energy. Okay, so it allows that function. Type 1 diabetics, they don't have that function, so there isn't any insulin. So therefore, because insulin does not come in a tablet form, you have to have injections which you inject into the muscle, and that's how you receive insulin. That's usually diagnosed at a much younger age, so children, teenagers, it's caught early because the symptoms are picked up. So that's usually about 8% of the diabetic population. Then you've got type 2, which is the rest of the, so I would say 90% is type 2 of the diabetic population, where there is some insulin, but it's just not enough. So the root cause of that is when you're insulin resistant, and that's what puts you at risk of type 2 diabetes. So there's insulin, but it's just not enough. And then you've got another 2%, which falls in type 3 diabetes, but it's very rare. And that often happens later on in life. So that is, it presents as type 2 diabetes, but it's actually type 1, but it kind of, it comes along in your 30s or 40s, even so, young adults, basically. But again, there are different investigations that you would go to find that out.
So as a non-medical person, what are the symptoms that, because type 1, I suppose, is a whole different conversation, and we're going to talk about type 2. As a layperson with no medical knowledge, how would I know that I have got diabetes, or what sort of symptoms would I be looking out for?
Okay, so with type 2, this is the problem. Often you don't get the symptoms unless your diabetes, has not been screened for, it's not been picked up. Okay, so then you might get symptoms of tiredness, increased frequency in urine, sudden weight loss, so that's where you've still got insulin, but it's just not enough. And caught at the right time, you can still manage it with medication. It just means that you might have to go on stronger oral therapy to first reduce the symptoms, okay? But if you are having symptoms of, being thirsty or you're going to the urine frequently, you will have to rule out type 1 diabetes. That's why it's so important that you start getting symptoms, you speak to your GP because it's type 1 until proven otherwise.
Okay.
Whereas the way to sort of identify type 2 diabetes is look at the risk factors. So if there's a family history of diabetes, or there's central obesity, or if there's a history of polycystic ovary syndrome, for instance, certain risk factors put you at a higher risk of diabetes. Therefore, you should be screening for diabetes, whether that's through a health check or whether your own personal concerns. For example, Asians, we're at higher risk, about 6 times more likely to develop diabetes than Caucasian European white population, right? So therefore, let's say, for example, 40 plus, you're at high risk of diabetes. But if you're Asian, well, actually, you should be maybe screening in your mid-20s or even 30s.
So what is it within sort of like the South Asian population that makes us more prone to diabetes as opposed to, like, say, the Caucasians? Because there are certain communities within sort of like the white community that actually do have a very highly processed, high sugar diet. So why is it that South Asians, especially with our cooking, is like a lot of fresh vegetables, a lot of freshly cooked food, and less processed stuff? Why are we still then, at risk of a higher prevalence of diabetes in comparison to, I don't know, say somebody who is maybe on a diet that is highly processed, the McDonald's diet, say?
Yeah. So it's the way Asians store the fat.
Right.
So unfortunately, majority of our fat goes around the abdominal first. And that's where the pancreas is. So the more fatty cells are around your abdominal, the more risk you are, the more abdominal fat you have around the stomach, the more insulin resistant you are, which means that the insulin is not able, your cells are just saturated basically with the fatty cells, so the insulin cannot enter the cell.
Right.
And that's to do with genes, our heritage, just the way, for example, 2,000 years ago, whatever, we were hunters, and we didn't know when the next food we were going to get, for instance, so the human body developed in a way where the best way to store glucose was in our fat T cells, and that's where, there's a lot more references in history to it, but in summary, we store our fat around the abdominal first, and that's what puts at high risk, and that's the reason why for Asians, you're at higher risk at lower BMI compared to others.
Okay.
It's a body fat percentage.
So that's interesting. So you mentioned earlier about sort of like diabetes in sort of like PCOS, and can you just explain for those, again, for viewers who are not sort of like medically prone or have never ever suffered with PCOS, what PCOS actually is and what the symptoms of that are, and how is that then related to a higher prevalence of diabetes?
Okay, so that's a very good question, but it's a very difficult one to answer because I think what you're alluding to is probably, well, what causes PCOS and does PCOS causes diabetes? So polycystic ovary syndrome, it's a metabolic syndrome. So therefore, it's an imbalance of hormones, including insulin. So patients with PCOS have a higher amount of insulin compared to others, which long-term makes you more insulin resistant. Therefore, puts you at higher risk of diabetes. And what does insulin do? Well, insulin increases your appetite. So if somebody has got PCOS, you can't just say to them, "Oh, lose weight and everything will be fine," because it's not easy. Because you've got this extra insulin on board, and it's a vicious cycle. And there's so much research still going on to find the cause and the effect. Does high insulin makes you more prone to PCOS, or does PCOS actually causes diabetes? Because there are some patients that have a low BMI that still have PCOS, but they're not, but they could still be at risk of diabetes because of the body fat percentage. So it's all to do with insulin. I don't know if you've noticed, but not once have I mentioned glucose or sugar.
No, you haven't. And that was like one of the things I was saying, because like people talk a lot about sort of like sugar, glucose, and that's what then leads to diabetes, etc. Now,
Yeah.
okay, are you actually going to blow that myth out of the water, or are you actually going to say, well, actually, they're right?
So glucose,
Mm,
we need glucose, okay,
mm,
for energy. But it's the type of glucose that you have. So if
mm,
you are going to have white refined sugar, you've got to think, okay, well, what's the nutritional value to it?
mm,
It's nothing, right? So anything processed, anything that comes out the packet, anything that's not in its natural form, it's not going to be good for the human body. Quite
mm,
often patients ask me, well, Reena, can I just, go on to juicing, or can I don't have time to eat fruits, so I just put all my
mm.
fruits in a juicer and just have that.
Yeah.
So quite often I'll say, well, look, God has made trees, God has got fruit, He's made
Mm.
fruits, if fruits were meant to be juiced, God would have made a juicer with it, isn't it? And they're like, yeah,
Yeah.
that's a really good point. I go, right. I go, so think logically, at
Mm,
the end of the day, the process of food starts from the mouth,
mm,
the digestion process starts from the mouth, the fiber that you get from fruit and vegetables, that's what's good for you. If you just
mm,
juice it, all you're doing, you're removing all the fiber that is meant to help you from the moment you put it in your mouth till right
mm,
till the end. Okay. And it's just going to spike up your sugars, which then is going to spike up the need of insulin.
mm,
Okay. So therefore, eat things how they're meant to be eaten, at the right time, right place.
mm.
Sugar itself, glucose itself, it doesn't cause diabetes as such. However, it doesn't help
Mm.
because it will spike your sugars. It will cause unnecessary weight gain because these are empty calories that
Yeah.
you're having, isn't
Yeah.
it? So
Yeah.
I always say focus on the amount, the balance that you're eating, the type of calories that you're eating.
Mm,
Um, and I try not to give a list of things that patients can eat or not eat, because I have to tell them, look, your tongue is your biggest guide. If you put something
mm,
in your mouth, the sweeter it is, the more sugar it's going to be. So even natural sugars
mm.
contain sugars.
Yeah.
However, you've got to then look at, okay, well, all right, how much sugar is in this fruit compared to the other?
Mm,
So, for example, if you're going to go for a run, that day, fine, have a banana, but the other days you might go for blueberries where you're not that active. It's all
mm.
about balance, isn't it? And what you're burning.
Yeah. And I
What do you
think
think?
that's one of the things that they say. So, because you mentioned earlier in terms of sort of like the juicing, etc. So, my question to that is, I mean, obviously, you do a lot of research into, basically because of the work you do, the writing, the medical journals, etc. Now there was a show. Oh God, what was it called? Fat, Sick, and Nearly Dead. Where I can't remember the name of the guy, but he basically went on a juicing diet, and every single meal over a 1 month, 2 month, 3 month period was just juicing. So vegetables and fruits. What are your thoughts around that? Like, if somebody has got type 2 diabetes and they want to shed the weight from around their middle very, very quickly, what are your thoughts on programs like that? Is that a dangerous program for people to watch and think, oh, actually, I can shed weight and become fitter and healthier just by juicing?
Personally, I think you should have a diet that's sustainable,
Mm,
you know, because juicing is not sustainable long term.
mm,
You're losing the fiber. It's not normal to have juices for the rest of your life. At the right time, right place, occasionally it's fine. So, for example,
mm,
if you're going out with your friends or whatever, green juice is probably better than having
mm.
10 pints of alcohol, right?
Yeah.
So you've got to put in context.
May not be as much fun though for some people.
No, no, fair point, fair point. I think anybody that comes to me and says, "Oh,
Mm,
I've heard of this diet, this low-calorie diet, 800-calorie diet.
mm,
What do you think?" And the answer to that is, "Well, look, I'm not a dietitian.
mm,
You know, I can give you my opinion from experience and what evidence shows. I can give
mm,
you science literature, the references. But if this is something that you'd like to do, then please allow me to refer you to a dietitian because they're the best in
mm,
terms of advising for people that want to do that. But my personal opinion in just juicing, I think it's not sustainable. You need to form habits that you
mm.
can sustain for the rest of your life to stay healthy.
Yeah.
For type 2 diabetes, I think all it's going to do is spike up your sugars
Mm,
because that's what you're having.
yeah.
And it depends on what level your diabetes is. I think, in fact, one of the things which I'd like to clarify is a lot of people think that their sugar is okay because they're monitoring at home.
Mm,
So when we look at somebody's control over diabetes, what we actually measure is their HbA1c percentage.
mm,
So what that is your average your blood glucose over 3 months. And we base the diagnosis
mm.
and management of diabetes based on that. Whereas
Yeah.
finger pricking at home tells you what your sugar is at that moment in time only,
Yeah.
which is only useful if you're
Mm,
titrating your medication like insulin
mm.
or certain oral medications, um, like glycoside, for example, then you need to check your sugar before you drive, for instance. Okay, but
Yeah.
otherwise, if people are trying to manage their diabetes with the finger pricking, then I
Mm,
think you must get advice from a clinician
yeah.
first before you start doing things like that.
So if, for example, you have got a patient who is borderline type 2 diabetes or is prone to it, what sort of advice would you give that patient? Would they go straight onto medication, or would they be given advice of, right, okay, let's try modifying your diet, increasing your exercise? What would be the process from the point of, and I'm going to take you right back to the beginning when I asked about symptoms,
Yeah,
because I do this. I think our conversations with this show, those who have watched it and you've watched it, I like to sort of keep it very conversational. So going back right to the beginning when we spoke about the diagnosis and what to look for, if a patient comes in and actually they are presenting with all the symptoms, they're, you've done the test and the levels are borderline, not quite there, but potentially could be, what advice would that patient be given, or would they be given medication immediately to counteract any further advances in their symptoms?
so thanks for that because that allows me to clarify the diagnosis of diabetes.
Hmm.
So when we look at high risk of diabetes, or some people use the term borderline.
Mm,
Personally, I hate the term borderline
mm,
because it doesn't really mean much in terms of practicality. So
yeah.
I usually look, when we screen for diabetes, we screen for HbA1c, so your
Mm,
average HbA1c over the last 3 months. Okay,
mm,
if that is between 6 and 6.4, then you're at high risk of diabetes.
mhm.
Anything at 6.5 or above, that confirms type 2 diabetes.
Okay.
And we always do a second reading to confirm that is diabetes, just to exclude any human error or lab error. But going back to those patients that fall between 6 and 6.4, where you're high risk of diabetes, that means you don't have diabetes. However, it could develop into type 2 diabetes at any point in life. Having said that, you could have a HbA1c of 5.8. So on paper, the blood test might show you're not at risk of diabetes, but other factors, so if there's a family history or there's central obesity, that will again put you at risk of diabetes. Or if you've had diabetes during pregnancy, short term, gestational diabetes, then although after the pregnancy you might not have diabetes, but you'll still be classified as a high risk of diabetes, and therefore you should have screening at least once a year. Or if anything changes in between, you have it sooner. So the process would be, I would explain how we come to that term, high risk of diabetes, what the HbA1c means, okay? And in terms of medications, no. At high risk in the UK, we wouldn't start medication just for high risk of diabetes. You might find some patients that has polycystic ovary syndrome, they may be on metformin, but that's for other reasons. So sometimes that might even mask diabetes, for instance, in the control of it. But diet and lifestyle is the key here at prevention. Because certain things we can't change. We can't change our age, we can't change genetics, our DNA, we can't change that, But certain risk factors we can change. So for example, if you're not doing any exercise, then 20 minutes a day is one habit that you can change. If you're not getting enough sleep, then change that as a habit, because lack of sleep, high stress hormones, that will then prevent you with your weight loss, and then that put you at risk of diabetes because then you're gaining weight. So I can't emphasize lifestyle changes and modifications enough, and it's probably the only way to prevent diabetes.
And that's what was the whole point of this conversation. So Cypria has just said, super insightful, thank you. Going back to the conversation that we set, we briefly touched on about PCOS and checking it. In terms of hormonal imbalances for women, why is it, and I know you can't answer for the whole of primary care, but it's just a question that has come about through discussions with women, that various women of various ages, saying that PCOS is something that presents itself quite early on in life. It's not necessarily going to present itself at the age of 50, 60 when you're perimenopausal, menopausal, or post. So why isn't it a general rule of thumb within general practice to actually check female hormone levels on a 6-monthly or annual basis?
I think in terms of PCOS, I think once your GP has diagnosed you clinically, there wouldn't be a significant, unless it's a clinical reason, there's no rationale for having hormones checked every 6 months.
The question is, it's not about after diagnosis, because there are a lot of women who suffer with PCOS for years without any diagnosis. And and sort of endometritis and a lot. And I know this discussion is about diabetes rather than female health issues, but because we touched on PCOS being a high risk factor for getting diabetes type 2, I guess the question is, why does it take so long before PCOS is actually diagnosed? And would it not, if we're talking prevention is better than cure, and again, I understand you can't answer this because, you do everything you possibly can within your practice to work with all your patients. But why isn't it a general rule of thumb in general practice to get female hormones checked on a regular basis as part and parcel of a full health check without women having to maybe book a private clinic or go to somebody else to do it? Why is that, do you think?
I'm guessing I'll have to double check that, but I'm
Mm,
guessing because it's not in the NICE guidelines in the UK as a
mm,
standard rule for these checks. But the one test which I would do is to
mm,
screen for diabetes. So, and quite often the other thing is that patients don't necessarily come to the GP
mm,
at the right time sometimes because they might just accept it
mm,
and that's it. So if they've been diagnosed at the age of, let's say, 16, 17, or 18, they might just accept it, but not go back to the GPs at some point and say, look, I've got PCOS, I'm putting on weight. Do you think I'm
mm.
at risk of diabetes, etc., or what can you do to help me? So
So,
sometimes it's go
sorry,
on.
please forgive me, I'm talking over
Mhm.
you then.
Mhm.
I know I get what you're saying. Okay, I completely understand that. But could it be that maybe they're not going back to their GPs because they may have been made to feel like they were just being hysterical women? Because we do know, and again, I'm not talking about the nurses, because in my experience, nurses have been phenomenal. And on the whole, there are amazing doctors out there, like for example, Dr. Trivedi, who we both know and respect, to the nth degree, is probably, sort of like one of the best GPs that I have ever
Absolutely.
come
Yeah.
across, because she's very thorough. But could it be that a lot of women don't go back their GP because they've been made to feel like they are just hysterical women and not listened to? So,
You're
what can be
probably
done?
correct.
What can we do to educate, within sort of like primary care, educate doctors to actually maybe be a bit more empathetic towards their female patients who may be suffering with certain symptoms but not others?
I think it all comes down to training
Mm,
at a sort of a level at university level.
mm,
So, for example, you're talking medical students, you're talking nursing students. I think that's where the seed has to be planted.
mm,
I remember, if I look back at my nurse training, well, we got a couple of modules on chronic management of diseases, but until I actually started primary care, I
mm,
didn't quite understand the depth of diabetes. So for me, when
mm,
I started as newly qualified, I worked on a stroke unit, and then for 2 years I worked in A&E.
mm,
But my perception was like, oh my God, this is preventable. I
mm.
need to be in a place where I could look at prevention. And for me, the best place was primary care.
Yeah.
And hence I went into primary care.
Mm,
Um, but so I think the understanding, the perception of polycystic ovary syndrome, but also menopause,
mm,
the understanding of that has to be taken seriously, just like how, we treat asthma or thyroid, for instance,
mm.
things like menopause or, hormone deficiency, because menopause is a hormone deficiency.
Of course. Yeah.
Exactly. So why is it that we look at a thyroid problem differently to
Mm.
somebody going through menopause or somebody going through hormone issues with their polycystic ovary syndrome?
Yeah. Or endometriosis or fibroids or all sorts. So,
Absolutely. So I think the
mm,
key is training, and which is one
yeah.
of the reasons why I try to write articles and pieces
Mm,
that would change practice for future clinicians.
yeah.
Um, which they could think, oh, okay, have a different perspective that, okay,
Mm,
I need to think about this, or I need to actually discuss this with the patient.
yeah.
And I think that's the key training,
Mm.
upskilling.
So maybe that's something we can talk about at a another
Yes,
another stage.
absolutely.
Reena, do you know what? I'm so sad to say that we are now at the end of the double. In fact, we've gone 5 minutes over the double 15 minutes. So, Reena, honestly, it's been such an absolute pleasure. So we had Rama Joshi watching. She goes, I am watching. She's watching the interesting topic, and I think it is, and I think we could talk so much more about it, but. Rita, tell me in terms of going forward, because you have got such a plethora of knowledge. Is this something that you might, do on a more regular basis, i.e., maybe have your own? I mean, I know you do write a lot of medical articles, etc. But do you think you might expand on that and do sort of like more articles for sort of like Joe blogs to the general public who don't have a medical background to start managing their own health?
I would love to. I would absolutely love to.
Mm.
And it's about, unfortunately, it's like, well, priorities and time. You know, there's so
Yeah.
much which I want to do. If you speak to my
Mm.
friends at times, they're like, "Oh my gosh, you're always working." You know, I
Yeah.
mean, it's a blessing that I love my job and I've been
Mm.
trained by amazing mentors,
Mm.
which has, got me where I am. But yeah, I think you'll be the pioneer of that, Rupa. You'll be leading the way.
I know. I
You
just,
can pick the topic.
I know. I will choose the topics for you. But no, honestly, I think it would be amazing. So, Jayshree Adnan has joined us. So I think we might go on a little more. I can't even get my words out. A little bit longer. So Jayshree says, "Why are doctors and consultants so aggressive and not sympathetic towards people who have complex illnesses which impact on blood sugar monitoring? I'm talking, despite diet control, it is always challenging. Why are they reluctant to investigate the impact, for example, fibromyalgia, mental health on diabetes type 2 with insulin? Why are patients made to feel bad and guilty about the diabetes because of some conditions outside that is beyond their control, like epigenetic and other ailments, impairments?" Hang on, I'm just trying to, and other, I think it's not actually given as the whole thing, so it's cut off a little bit,
Mhm.
but other ailments or impairments.
Okay. Honest answer, I feel that a lot of the times doctors, nurses, there's a
Mm.
protocol and there's a process that they have to follow. I can't answer
Mm.
for everybody else, but I
Yeah.
know that within my practice,
Mm.
I try my absolute best to consider other factors as
Mm.
well. Because, mental health, mental well-being is so important. So it's a
Mm.
vicious cycle.
Yeah.
So quite often, sometimes, although they've come to see me for their diabetes, we might
Mm.
not have a discussion on diabetes. It might just be the case of, okay, so, what is it that you want to speak to me about?
Mm.
And it might just be the case of, well, resolving anxiety, depression, short-term course of an antidepressant, for example,
Mm.
might just make them feel better. And if they're feeling better, then they're much able to take better care of their diet, the sleep. It's like if they're not sleeping well, they're gonna have a rubbish night. You're gonna wake
Yeah.
up feeling rubbish. You're not gonna be able to think straight. So it's a vicious
Mm.
cycle.
Yeah.
The only way to resolve um, this in terms of doctors and nurses is training,
Mm.
and without feedback from patients, it's very difficult,
Yeah.
to sort of know. So sometimes I think there's nothing wrong in giving your clinician that honest feedback that
Mm.
this is how you felt. They might
Mm.
not be aware of it, that this
Yeah.
is how somebody,
Mm.
felt. So I personally always appreciate it when I get
Mm.
feedback from my patients because that allows me to get to know them better.
Mm.
Unfortunately, secondary care clinicians, they don't have that relationship with their patients, whereas
Yeah.
GP and practice nurses, they
Mm.
know the patient, they know the family, and you
Mm.
know maybe that's where the difference is.
Yeah, and,
Mm.
and I think it's just sort of like you said, it's the education side of it. Because I mean, Josh was saying she has PCO, hormonal imbalance, overactive thyroid. She's got PTSD because Joshua was a guest on the show a few weeks ago, and she hasn't had good sleep. She's saying ever in her life. She's been through trauma from childhood, all the way through to adulthood and abusive marriage, but I guess it's sort of like it's so much more complex, and like you said, it's the education side of things, isn't it?
Mm. Also, I mean, I wish I could refer many patients,
Mm.
to a health psychologist.
Yeah.
So they somebody might not necessarily have clinical depression or
Mm.
or a mental health diagnosis.
Mm.
However, you know, they just need that little bit of help to
Yeah.
see things from a different perspective. But unfortunately, on the NHS, we don't have enough. And sometimes I think, well, if you just increase the amount of health psychologists we have, then it might help acute problems, isn't
Yeah.
it? Because actually
Mm.
managing diabetes with the medications and therapies that we have available
Mm.
now, it's actually easy. But us
Mm.
as people, we're complex.
Of
It's,
course. Yeah.
you know, um, and I mean, I know, sometimes, for example, when you're busy and you're working, well,
Mm.
yes, it's all very well. You've got to do 10,000 steps a day to stay healthy, fit and
Yeah.
healthy. But I would have to go from a 5K run to make up those 10,000 steps or walk for an hour. And
Yeah.
some days you just can't be asked. And,
Well, the thing is, though, also, Rena, they say 10,000 steps. As somebody like me, who's 5'7" and a bit, I've got very long legs. So to do 10,000 steps, I have to probably do like a 10K walk in order for me to get
look at that.
in order for me to get the 10K steps. And I've
Wow.
had it where I've done like a long walk, and I've gone with a friend, and their steps, they've managed to do 12,000 steps, and I've literally only got about 7,000 steps, and it's like, what, 5,000 steps, even though we've done the same. So I guess I get where you're coming from, but I think it's, I think what sort of like, sort of like the, I suppose the multitude of illnesses that sort of like more complex cases will be a discussion that we can have maybe at a later stage, to talk about it. But for now, Reena, thank you so much for joining us. Any last bits of advice for our viewers in terms of, prevention being better than the cure? What can people do today that is going to help them, I suppose, take a step further to preventing type 2 diabetes?
I'd say stay away from processed foods.
Mm.
Anything that comes in a package, comes in a bag, you know, just think, how is that going to benefit your body? Okay.
Mm.
Stay active, whatever you can, whether it's 20 minutes a day, 10 minutes a day, but do something, but change one habit at a time. You know, just because you're a high risk of diabetes or you have diabetes, and don't stop living. It's not about stopping good food, or even if you're South Asian, not about stopping Indian food. I only eat Indian food, apart
Mm.
from porridge and maybe occasional protein shake. But that's me, right? So eat what you like, eat at the right time, stay hydrated, sleep,
Mm.
get enough sleep in, and in summary, go back to basics. Go back to basics. Your body is your best advisor. That's what I
Mm.
say.
Yeah, no, absolutely. And that's the thing we need to remember. Reena, thank you so much. You've been an absolute pleasure. And I know you're normally used to doing the other way around and interviewing. So thank you. You've been phenomenal. Really appreciate you
Oh,
joining
thank
us.
you. Thank you for the questions, people.
No, that's amazing. No, we do have some brilliant support with the viewers and stuff. So, Rita, thank you. So I'm just going to sort of like say, so we will be back on we're hoping to be back on the 30th of December, where I will be interviewing Helena, who is a phenomenal tattoo artist. And we're going to be talking about her journey into the world of tattooing. And those of you who know me know that I love my tattoos with all however many hundreds I've got. But she'll be joining us on the 13th of December, 8 p.m, Facebook Live, YouTube, and LinkedIn. So until then, stay safe, everybody. Those in the UK, it is snowing, it is icy. Stay safe on the roads, and thank you all for joining, watching, and your questions. And I will see you soon. Take care. Thank you again, Reena. Bye.
Bye.